Hello, everybody, and welcome to our third or fourth installment of Burning Migraine Questions. My name is Ziv Peled. I'm a plastic and peripheral nerve surgeon specializing in surgery to treat chronic headaches such as migraines. And I'm actually coming to you live here from vacation in Maui, but as these are called Burning Migraine Questions, supposedly there is some urgency to them, and life doesn't stop even when you're on vacation. So I thought I would take a slightly abbreviated version of this and keep our trend going, as we've had such a phenomenal response to all of the questions that have come through. So hopefully there are a few people here that are joining us. And we will start going through actually many of the questions that have come through over the last week or so since our last Burning Migraine Questions Facebook Live event, and see how many of these we can get through so that we can also begin to address some of the questions that inevitably come in during the event itself. One of the first questions that is in our queue here is that from a woman named Nancy, and the question is it possible to have surgery on all of the areas at the same time? The question is you can do, or the answer rather, is that you can do anything. It's certainly possible to do that, but it's not something that I recommend, and I say that for a number of reasons, okay? The first is, and this really gets to the question of why would you want to stage these procedures if you could? Let's say you could very safely operate on all 14 nerves, 7 on each side, in the front, in the temple, in the back, and perhaps even in the nasal area in one operation. Why would you not want to do that? Well, there's a couple of reasons for that. Probably the biggest reason that I recommend staging these procedures is that often there is an area that is worse than the others, and worse can mean anything that the patient wants it to mean. It could be the area where the pain is most severe when it occurs. It can be the area where it occurs most often. It can be the area that triggers all of the other areas, and is therefore the fuse that ignites everything else. In that case, it is certainly possible, and I've seen it many times, that if you defuse that one area, so let's say the occipital area is the area that tightens up and is what causes the pain in the temporal and frontal regions later when it's allowed to flare up or it flares up uncontrollably, then presumably if you're able to treat the occipital area, those other areas do not flare up. And that happens a reasonably frequent percentage of the time. I would say close to 50% of the time. And that would mean that if you operate on the back and you get good relief, you'll never have to operate on the temple or the frontal regions. Another reason to stage these procedures, in other words, to only do one area at a time, has to do with the safety of these types of procedures. So while they are extremely safe, I've actually never had a patient have a significant problem thereafter, such as heart attacks or strokes or anything like that. Wound infections are very, very uncommon, probably less than 5%. And bleeding complications are things that are almost unheard of. I've never actually had one of those. However, the recovery from these operations can take a long time. And the analogy that I give to patients, as we mentioned, perhaps if you've joined us during our last Facebook Live event, is that the analogy would be much like if you had fallen asleep on your hand for only an hour or so and the fingers were a little numb. You'd shake your hand out probably for a few seconds and everything would come back to normal very quickly. Every once in a while you fall asleep on your hand or arm for several hours, and when you wake up, not only are the fingers really, really numb, but sometimes the wrist is somewhat paretic, and you have to shake it out for a few minutes before the blood starts to flow and the nerves start to work to move the muscles. And then when the nerves come back, or sorry, the sensation and blood flow comes back to the fingers, it can sometimes be hypersensitive. And when you're talking about recovery from surgery where you've had compression on these nerves for sometimes decades, it is that same process in that second scenario, but carried out to a significantly longer, or on a significantly longer timeline. And so it can certainly be the case that if you've had compression for decades, it could be easily 3 to 6 months before you notice any result from surgery. And that means that if you've operated on the back and you haven't noticed any results yet, and you wait up to a year and you still don't notice any results, it is presumably the same pathology in the back that is going on in the other areas that you experience pain, for example, in the front and in the temple area. And therefore, if it didn't work in the back, it may not work in those other areas. And the converse is also true. In other words, if the pain is bad everywhere, and you really have three independent trigger zones, the front, the side, and the back. The back is the worst, so you treat that first, and within 3 to 6 months, you have excellent results. It gives you a better sense, and you are more confident that ultimately surgery, if you have persistent pain in the front and in the temporal regions, will also benefit those areas. And then, of course, there's the simple issue of recovery. Obviously, if you have incisions all over your head, it's very hard to find a comfortable place to lie down on your back, on your side, on the front. And so recovery and rest after surgery is incredibly important. It's something that I tell my patients to pay attention to very, very carefully and to optimize that part of their recovery process, because it will optimize their overall outcomes and hasten the ultimate result that they get. And so if you operate on all areas of the head and neck on both sides in one operation, it can be a very, very difficult recovery, which in many cases is not necessary. We've had another question here talking about vitamin B12. This patient says, Debbie, that she, and we've had this question a number of times, her occipital neuralgia symptoms developed all of a sudden. They came out of nowhere, and she's questioning whether or not it can be related to vitamin B12. Well, that's a good question. Vitamin B12 deficiency has been associated with various kinds of neuropathy because vitamin B12 is an important vitamin to help the body maintain something called the myelin sheath of the nerves. And all peripheral nerves have a myelin sheath. You can think of it as a coating or a rubber housing around the wires, much like you have on any wire, for example, from your computer to the outlet in the wall. The actual copper fibers are inside, and the thing that you hold on when you plug in and take the plug out of the wall is actually the rubber housing, and it helps the conduction for those wires occur much more efficiently. When you lack vitamin B12, the production and quality of that myelin sheath, that housing that allows these nerves to conduct efficiently, goes down, and you can actually have significant nerve damage. And obviously vitamin B12 deficiency has been associated with various types of neuropathy, specifically peripheral neuropathy. And so it is certainly possible that a vitamin B12 deficiency could be a reason for occipital neuralgia. That being said, there are no studies that have definitively linked occipital neuralgia to vitamin B12 deficiency, but if you're concerned, and for example, it is one thing that is common in people who've had various types of intestinal operations, for example, for Crohn's disease, people with very restrictive diets, and this is not a judgment by any means, but a vegan diet, because many of the sources, dietary sources of vitamin B12 come from animal products, whether it's meat, fish, poultry, or dairy products and eggs. And so people who have very restrictive diets that don't include any of these substances actually may be deficient. So if you feel that you are deficient, it's important to have that checked. And if it's deficient, it's certainly something that you might want to speak to your primary care physician about optimizing in your diet, and then follow your symptoms carefully. And if they don't improve, then at least you've ruled that out as a possible cause. Another patient here asked a very interesting question, which is a little bit more rare of a phenomenon. This person named Marjorie says, when my ON flares very badly, it feels like my right ear is hot and someone is stabbing a knife in it. Could the auricular nerve be affected as well as the lesser occipital nerve? And this person says that they've had occipital neuralgia for 36 years following a car crash. Very, very interesting question. And this is something actually known as red ear syndrome. It's actually a very rare phenomenon. And the pathophysiology, meaning the cause, has actually been very, very poorly understood because presumably it's such a rare phenomenon. It is thought that what occurs in these particular patients is when the nerves are firing uncontrollably and hence causing an occipital neuralgia flare. Because remember, occipital neuralgia just means occipital, meaning a nerve in the back of the neck, neuralgia, nerve pain. So that nerve is malfunctioning, and when that nerve malfunctions, it actually sends signals erroneously both back and forth. Okay, when the either auriculotemporal nerve, the greater auricular nerve, or the lesser occipital nerve, which all provide some degree of sensation in and around the ear or auricle, is misfiring, you can actually get an antidromic signal, meaning a signal that's going backwards. And when that happens, it can actually cause release of vasoactive peptides, basically fancy doctor speak for chemicals that cause the blood vessels in the skin around the ear to dilate. And when the blood vessels in the skin dilate, there's more blood that flows to the area and the ear becomes hot and red. So those nerves are already flared up, and that is why you have the discomfort and pain that is sometimes associated with these things, and that is what is thought to be the cause of the red ear syndrome. Does it mean it is an absolute hallmark of occipital neuralgia? No, it does not. It is a very rare phenomenon, but it certainly means that there are misfirings of the nerve, and there have been reports that when you block either the C3 nerve root, from which many of the occipital nerves emanate. So for example, the lesser occipital nerve has contributions from the C3 nerve root. Or when you do a peripheral nerve block, in many cases within a few minutes, the redness disappears. So that signals to you that the misfiring of the nerve, which is causing a dilation of these blood vessels, is also improved, and it suggests that some type of surgical procedure perhaps to more definitively treat the irritation or irritating factor of these nerves, for example, a compressive band or blood vessel, may also be effective. So that's a very, very good question. We have had another question about a patient who's got Ehlers-Danlos syndrome. These get to be very, very specific here, and they are not reacting to the blocks. And have they been successful with surgery? Again, a very, very interesting question, but something that is somewhat controversial in the medical literature. There were a few papers way back when, actually in the oral maxillofacial literature, that suggested that people who have Ehlers-Danlos syndrome, which is a connective tissue disorder, are somewhat refractory or resistant to the effects of local anesthetics, and that is certain types of local anesthetics. And it has been related to a specific gene whose name I can't recall offhand. However, despite the results from this initial set of papers, there have been more recent papers that do not find those same findings, again, in the oral maxillofacial literature predominantly. So it remains controversial as to why some people with Ehlers-Danlos syndrome, which does seem to be a real phenomenon, are refractory to local anesthetics. That being said, I think there are two types of local anesthetics, and it's something that doctors should consider when saying people are resistant to a local anesthetic. There are amide local anesthetics, and then there are other types of local anesthetics. And if you are resistant to that first type of local anesthetic, you may actually still respond to a different kind of local anesthetic. And so you need to talk to your physician, whoever is injecting you, to see if there is a possibility for using those different class of local anesthetics, ester local anesthetics, to hopefully provide you some diagnostic accuracy in terms of if you have a good result with that block, then again, you have a reasonably good chance for surgery working. And that sort of dovetails very nicely with this next question. This person said, what qualifies you for nerve decompression surgery, and what disqualifies you? Are there instances where surgery will not help occipital neuralgia? And the answer is certainly yes. Okay, the three general criteria for someone being a good candidate for nerve decompression surgery are: one, a good history consistent with a peripheral nerve or nerves causing their pain that you can identify; two, a good physical exam that corroborates that history of a peripheral nerve pathology, irritation, entrapment, compression, whatever, causing those symptoms. And then finally, a good result with the nerve blocks. So typically, if you have a good result with all three of these criteria, you are a pretty good candidate for surgical decompression, and the chances for a successful result are close to 90%. Now, let's be very careful when we say that. What defines a successful result? That's actually a very important question. And in the literature for these, amongst the few of us that actually do a lot of occipital neuralgia and trigeminal branch neuralgia surgery, such as myself, it is well accepted that a minimum 50% reduction in frequency, severity, and or duration of symptoms is what qualifies you as being successful. In addition, it is very important that with that third criteria, you have what I call a wow result. In other words, when someone comes in and says, I have occipital neuralgia, I often ask them to come in as much pain as they can tolerate and actually still walk into my office. The reason for that is because if I can take their pain and make it go from a 9 to a 1 or a 0, that's going to be very compelling both for me as well as for the patient that we're really on the right track. If they come in and the pain's only a 4 and we make it go to 0, that's nice, but it's much less of what I call a wow factor. And the people that, in my experience and my belief, who have the best results with surgery have very dramatic results with their nerve blocks. They don't tell you, well, I'm a couple of points better. I was an 8, now I'm a 6 or maybe a 5.5. If that's the only result you have with a nerve block, despite blocking several different nerves, then perhaps there's a musculoskeletal cause or some other issue that you haven't identified. There are also other instances in which certain things can be causing nerve pathology that are extrinsic to the nerves themselves. So for example, if you have a tumor growing somewhere and that is putting pressure on the nerve, yes, you have neuralgia, nerve pain, because the nerve is being irritated, but obviously the nerve is not the problem there. It's the lesion or tumor that is growing and pressing on that nerve. And it is one of the many reasons that preoperative imaging is actually so important, because if you find something like that, obviously the answer or the treatment will be to remove the tumor and hence the pressure on the nerve, and not to either decompress that nerve in some other way or to cut that nerve and bury it in the muscle. Okay, and that actually dovetails with the last question we'll probably be able to get to today. We'll see how much I talk here, but a lot of people ask me, why is it that when I have barometric pressure changes or a cold that my symptoms seem to flare up? And there's a couple of reasons for that, and we touched on this in our previous Facebook Live event. First of all, a lot of these nerves, especially in the occipital region, but also in the forehead and the temple area, pass alongside blood vessels. And in some cases, and I've seen this many times, the blood vessels are several times larger than the nerves themselves, and that's not typically the case. In fact, it's usually the reverse. The nerve is a little larger than the blood vessel. When you see a very large blood vessel pressing on a nerve, that indicates to you that when that blood vessel becomes engorged, it can actually put additional pressure on that nerve, which is probably already present at baseline. And so if you bend down, for example, and blood flow rushes to your head and those blood vessels dilate, you're going to put more pressure on that nerve. That is why sometimes people say that bending over is a trigger for their, quote, migraines. Second of all, if you have changes in barometric pressure, if you've ever watched the meteorologists on TV, they'll say a storm is coming and you have an area of low pressure coming in. Those two terms seem to be synonymous. And so if you have low atmospheric pressure, there's less pressure pressing on all of the structures in our bodies, including the blood vessels. So once again, those blood vessels will dilate and put extra pressure on the nerves. Much like nerves run alongside blood vessels, certainly in the head and neck area and the occipital area, the occipital nerves often run next to lymph nodes. And obviously, if anybody's ever felt under their jaw when they have a cold or a flu, oftentimes you'll find these little swollen areas, and those are lymph nodes that are tender because your body is creating a lot of white cells, which are made in the lymph nodes to help fight the viral or bacterial infection that you have. Therefore, much like any extrinsic compressive force, when these these lymph nodes become enlarged, they will press on the lymph nodes and cause pressure. So again, in that case, the treatment will be to optimize your recovery and treatment of the cold or flu. So if it is a bacterial infection, such as a bad sinus infection, you want to get on a course of antibiotics to help your body heal that faster. And when those lymph nodes shrink down in size, your symptoms should disappear. Now, what you might find, and this is actually an important point, is that just because you feel 100% better and you don't have any more of a productive cough, or you're not blowing a lot of productive things out of your nose anymore, and you don't have any fevers or chills, sometimes your nerve symptoms may persist for a while, and that is because you've had pressure on those nerves for several days or a week or so, and there is an after effect of that pressure and an irritation of those nerves that will persist sometimes for several weeks beyond that. But typically, within a few weeks after treatment of a cold, for example, the nerve symptoms disappear if that was the cause. So I think we are just about out of time for today. I see we have a lot more questions that have come in, and I really appreciate everybody tuning in. I am on vacation here, and I appreciate everybody showing up, and we will be back to our typical schedule next week. And we'll try to go back to half an hour. Once again, I really appreciate all those people that send in the questions. Please keep them coming. These are great questions. They're questions I hear a lot, and I don't think there's any way to emphasize these enough or to talk about them enough. And please tell everybody about these events. The more people we have here, the better it will be for everyone. Thank you again for joining us, and hope to see you next time at our next Burning Migraine Questions.